Good morning, everyone, and welcome to the Opioid and Other Drugs virtual series. For those of you who haven't joined us yet, good morning. My name is Adrienne Luckenbacher, and I'm one of the moderators for the webinar series today. Today, we are going to be joined by Shannon McKeever, and she is going to be presenting on how to get on the same page, working with adults and youth who present with resistant behaviors. We want to remind everyone that this webinar series is provided by St. Clair County Community Mental Health in partnership with the Community Services Coordinating Body. And this series is made possible by a grant awarded by SAMHSA, which is the Substance Abuse and Mental Health Services Administration. We are, again, as always, like we've talked about every time, wanting to remind folks that National Recovery Month is in the month of September. And this is one of the reasons that we're fortunate and able to do the webinar series during the month of September. We first go through and do some housekeeping that many of you have heard several times if you have tuned into our webinar series, so we'll make them quick and roll through them. First, today's session is being recorded. The second thing is we want to encourage folks to use the chat feature to enter in any kind of questions throughout the presentation. We can't guarantee we're going to get to questions, but we definitely try our best to. We also want to remind everyone to use that chat feature to not only ask questions, but share any kind of resources or valuable information that you have with the rest of the viewers with us today. Continuing educations are offered today for individuals who have registered for CEs through our website. Just a quick note that this session is being recorded and it's also being shown on Facebook Live. However, continuing education credits are not eligible for folks that watch it on Facebook Live, nor watched later on when it's recorded, only for the live webinar today. If you requested continuing education credits, please make sure when you logged on to the Zoom today that you use your first and last name, and it needs to be your first name, full, and your last name. For any reason, if you abbreviated or did something different, you can go ahead and log back out and then log back in with your full name. We would greatly appreciate that so you can get the credits that you deserve. Also for CEs, please make sure you're logged in for the entirety of the webinar until the end. If you find yourself losing connectivity or kicked out for some reason, go ahead and log back in and you should be fine. CE credits will be given to those, but you have to complete a short quiz and a survey at the end of the webinar. We'll give you more directions about that at the end. And let's see. Oh, we do have an in and out code. So we want to remind you of what those are. Today's in code for the series is the word adult, all capital ADULT. So the in code for the series is adult. Now we're really excited to go ahead and move into our presenter for the day, who I know personally, Shannon, who's great. We're very excited to have her. Shannon McKeever is a fully licensed MSW and a certified advanced alcohol and drug counselor who specializes in a lot of treatment modalities. Shannon has worked in private outpatient services. She has also taught at Baker College. She is currently a clinician working with individuals with recurring diagnoses here at St. Clair County Community Mental Health. And with that, I'd like to turn it over to my friend Shannon.
Thanks, Adrienne. Okay, so hopefully everybody's doing okay today. This is the first time that I've done a presentation without people in the background for feedback, so please bear with me in my learning experience for that. Today we're going to talk about working with adults and teens who present with resistant behaviors. Kind of how we can get on the same page. So the objectives for today are, by the end of the presentation, you'll be able to identify what resistant behaviors are and how they affect treatment, identify secondary gains that may be creating resistance to engagement with your individuals, and identify contingency management and gaining the knowledge about its effectiveness. So I know that we had a poll for at the beginning, and I know the moderators were going to try to assist with getting that up and running for the first poll, just so I can kind of get an idea of where everybody is at, what setting you work in. So I don't know if you guys can bring up that poll at this time. And we're just going to take a few seconds just to kind of click on this so I can kind of have a general idea of who I'm speaking with. Typically, I would ask by like a show of hands, but at this point in time, obviously, we're not doing things in person, so it'll be a little more challenging. So this is the best way to see it. So it looks like almost half of you are community mental health. Some people are working on a degree, doctor's offices, hospital, got a few people in private outpatient, and a good portion in other. So kind of have an idea of, that a lot of you work in a community mental health setting, either here or in other locations. So just thank you very much, and we'll move forward. So what is resistance? Resistance, hold on, I need to just move, there we go. Resistance, according to the dictionary.com, when you're talking about psychiatry, is an opposition to an attempt to bring repressed thoughts or feelings to the consciousness. And then there's also another definition, a psychological defense mechanism, wherein a patient rejects, denies, or otherwise opposes a therapeutic effort for psychotherapy. So in other words, we're looking at things that kind of get in the way. You're going to be bringing up emotions that people have avoided for a period of time. And some people actually worked hard on repressing memories and not necessarily interacting with thoughts and emotions, feelings, experiences. So that can create resistance, knowing that this is going to be something that's going to be brought up. I've had many individuals come in and talk about that they really don't want to deal with things. So they're a little resistant to engaging in services. There'll be times where we are starting a conversation. They're like, I really don't want to go there. So just that's one thing that kind of can create resistance. So let's take a moment and think about something that has been a large part of your life, a habit that you were looking at changing. Just kind of take a moment and sit with that and think about that for a moment. Now, when you think about something, think about somebody telling you you need to change it, or going in somewhere knowing or feeling that an expectation is that you need to change it, whatever this is. We're talking, when we're working with people with substance use disorders, we're talking about people that some of them have been using for 20, 30 years and is really ingrained in who the individual is. So it's scary. It's really scary to think about changing. And when you're walking in somewhere, thinking about that's what the expectation is. Some people are brought in because of a probation officer or a court order. And so they're not necessarily there for their own choice. And also we still need to engage with them. We still need to work with them to be able to see what we can work together to move towards. So I've just got a short video right here. So I'm going to play it really quick. Oops, sorry.
It's just, there's all this pressure, And sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just... Sometimes it's like there's this achy... I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. If you would just...
Don't...
Try to see things my way. Do I have to keep on talking till I can go on?
Okay, I'm hoping that you heard that. And the reason why I showed that is because a lot of the times we're moving towards, we have ideas where you notice that he had his own agenda. He's talking about the nail, and for her, she just kind of wanted to be heard. She just wanted somebody to listen. And so even though sometimes we may see things, an individual might not be ready to look at those, may not be ready to really experience or express the things that we can kind of see in our own way. So I guess one of the most important things when we're looking at working with individuals is taking the time to listen. That's one thing that I've really kind of gotten a lot of feedback from my individuals. And one thing that I've learned is taking the time to just really let a person speak, because that might have been the first time that you're allowing them to do that. So as a provider, things that we can do is, first of all, kind of look at our agenda and know that it's not ours. Know it's about our individual. Know that agendas are very fluid, that just because we started in one place because we have to do a plan of service at the second meeting, sometimes the first meeting, just because we're starting there doesn't necessarily mean that needs to be the focus all the time. That's a fluid document. That's the reason why we have amendments. That's the reason why we can change it. People can start in one place and then need to go into a different direction. And for them, it's very important for us as providers to let them lead. You'll see on my fourth point that, are we playing a tug of war, or are we dancing with the client leading? Are we trying to come in with some type of agenda, come in as an expert in knowing what is right, what we're supposed to do? Or are we allowing the person to really be the expert in themselves? Kind of exploring if we're listening to respond or if we're listening to understand. When it comes to resistance, people will really become defensive if they don't feel like they're being heard. And it's really hard for them to feel comfortable to have yet another setting of somebody telling them what to do or telling them how to do it. You go to your family members, you go, everybody knows best for you. And so when somebody's in recovery, and things that I've learned from my individuals is that they just want somebody to listen and understand where they've been and what their recovery looks like, and how moving forward looks to them and where they're at. You may have people in pre-contemplation, contemplation, preparation, action, and looking at and being able to follow along with individuals wherever they are and meeting them there and moving forward. What's their motivation to being with you? Again, as I had said, sometimes it's court ordered, or you have a probation officer that says that they need to be there. And so what does that look like for them? And, you know, how do they feel about that? And listening to them about how that experience is. I know that a lot of times I've had probation officers tell me, you know, you have to work on this or that with them. And again, I always try to encourage my individuals, encourage and educate probation officers or whoever I've spoke with that it's about where the person is. And I get that there's an agenda, and also it's about where our individual is and where they need to go. Making it a safe place to have a conversation. When we're getting a consent to talk to people, to talk to POs, to talk to doctors, I really kind of have that whole conversation with, you know, what exactly do you want me to be able to talk to them about? If it's just about attendance, if it's just about engagement, you know, that provides a safe place for them, because then they're not afraid if they drop dirty on a UDS, urine drug screen, that we will then call their PO, and the probation officer or parole officer will have knowledge, because we want this to be a safe place for them. The safer a person feels, the more engaged they can be. It's hard when you feel like you're going to be told on, or that there's going to be some type of external confrontation or consequence. It's hard to really be as honest as you possibly can be. We, a lot of the times, do urine drug screens here to ensure that we know what's in somebody's system for medication purposes, because we also have psychiatric services here. And so we do that for a benefit of their treatment, not for the benefit of knowledge for anybody else. And if we're not in the same place, we may be addressing something that's not on target. If we don't really kind of explore with the individual on what they're looking for, what they want, we'll end up in that tug of war, and there's no benefit to being in that. Children and teens and resistance. If you think about your childhood, or if you've ever worked with children, you really look at kids' lives are very micromanaged. The older they get, it's not as micromanaged, but there's always somebody that has an opinion for them on how they should, what they should, when they should, fill in the blank. And so when working with a child, or working with, you know, children and adolescents, and I keep them separate because it's definitely different stages of change with them. You know what? I forgot to ask for that poll. Is it possible to pull up the poll so I can get an idea of what age ranges that everybody is working with right now? Just so I can have that idea. Just take a couple seconds for that. All right, so we have a lot of people that are working with adults, some that work with children and teens, and a lot of people that work with both. So it sounds like the majority work with either adults or both children and adults. So, you know, working with kids that their lives are very micromanaged. You have teachers telling them what to do, parents telling them, and as I said, somebody always has an opinion on what or how they should do something. So when working with teens, it's definitely about hearing them. Working with children, it's hearing them, it's listening to them. You represent a population as an adult of telling them who and what to do, but you know, who to hang out with and what to do and where to be. And we're also trying to assist them with being heard. Sometimes I've heard that, you know, that I'm the first adult that really they feel like listen to them. Taking a kid and asking them why, asking them, what does that mean for you? When they're choosing to do whatever, if you're choosing to smoke marijuana, per se. So I have worked with a kid that smoked marijuana quite frequently. Parents didn't understand what was going on. I needed to, quote unquote, fix them. So working with this child, what does pot do for you? How does that help you? And we found out that it helped the person slow down, had racing thoughts. This teen was able to slow down and focus more, relax more. So then we started working on anxiety because that's where the person was. And being able to find out what that substance did for them and what that meant for them, instead of having a conversation of you shouldn't do that, but instead, what does that mean? It allows you to be able to better understand where they're coming from. And then the child, the adolescent is able to feel heard, feel seen, feel respected, and also explore things with you and know that there's other options to be able to manage what they're trying to manage, what they found the substance to do. A lot of the times when people use substances, it's because it's meeting a need of some sort or other. They find the substance that best fits for them. I always say, your drug of choice is the one that speaks loudest to you. And so, allowing them to express how it speaks to them, so then we can adjust or explore, or wherever the person is and what's ready to do to move forward and help them with their best fitted treatment. So I have another video, and this is kind of a what not to do. So we're going to watch the video, and then I'm just going to kind of talk about some of the things that I've seen in it. This is about motivational interviewing, because a lot of resistance trainings are focused in motivational interviewing. Motivational interviewing really kind of focuses on allowing a person to take the lead, and there's a lot of different ways that they do this. So just kind of watch this example of kind of what not to do.
Well, hey, Miss Clark. My name is Alan Lime. Dr. Seal asked me to talk to you about your drinking.
Oh, okay.
Yeah, he said that you filled out the form and that you came to him for some medication for your stress, but that he was really concerned about your alcohol consumption before he made any prescriptions for you. So let me see that form, please.
Okay.
Thanks. Yeah, well, it says here that you drink 4 more times a week, and that you have 1 or 2 drinks, and that you go over that limit on a fairly regular basis. That's too much. That's too much. I mean, I imagine that he's already told you that he can't prescribe you anything unless you do something about this drinking.
Okay, I'm really confused. He did want me to come and talk to you. I'm just not real thrilled with the way this is going.
Well, I'm sure you're not, because anybody that drinks at these levels isn't going to be thrilled talking about their drinking with a professional like myself. What we know is that if you continue to drink at this rate, you're probably going to wind up drinking more and more, and I imagine that's his concern, is you're going to wind up to be an alcoholic.
I didn't think I was drinking that much. I mean, well, 1 or 2 glasses of wine
how big
a
is the
night.
glass? I mean, this is a typical glass, which is 5 ounces of wine. But what I know is that most people drink a lot more than that. So
Well,
I'm pretty sure that your glass is bigger than that one, wouldn't you say?
you're not in my household. You don't know what I drink.
Yeah, I know,
It's about that size, maybe a little more.
I've never been in a house where they have these stem glasses. That's only at restaurants. Most people have tumblers, so I imagine that's what I'd find if I opened your cupboards.
Yeah?
No.
Yeah.
Well, anyway, so what he said was that you came to him for some kind of benzodiazepine, something for anxiety, and we can't prescribe anything like that if you're drinking at these levels. So we need you to stop, or at least cut back to reasonable levels, which for you would be no more than 3 drinks in one setting, which you're drinking over that now, or no more than 7 drinks in 1 week, which you are well over right now. If you can agree to that, then perhaps he can make that prescription for you. I can't promise that either, but that's certainly one thing. The other thing you need to do is to read this, take this pamphlet and read it, and you'll see in there that it tells you about limits of alcohol, and I think you'll find that if you can stick to that, you should be okay. He may be able to prescribe you the medication at that point. I'm not sure, I can't promise. But if you do have problems, and I suspect you may have problems cutting back to those levels, then we can make a referral for you to a counsellor to come and talk about your increased drinking. You have any questions for me?
No questions at all.
All right, well, thanks, and I'll tell Dr. Seal that you came in and that you were reasonably compliant and that you said you'd follow through.
You can tell them whatever you want.
All right, thanks.
So with that video, I mean, you heard him say that lots of assumptions. I know your glasses are bigger than this 5-ounce glass. I know that it's hard to hear from a professional. Like he's coming on as this expert, telling her what to do, how to do it, and kind of really, telling her has an alcohol use concern when she's not even recognizing that there's a concern at all. So if there even is an alcohol use concern, she would definitely be in the contemplation stage, and he was addressing her in a way that definitely wasn't listening to what she had to say, or meeting her where she was at. She became argumentative, kind of angry. You noticed her body shift. She was sort of facing him, arms crossed. Then she turned away from him, arms crossed. Her leg had started bopping in between that. He handed her the pamphlet. She grabbed the pamphlet. She set it down. She didn't necessarily look at it. I mean, there was a lot in that. She kind of sat there in silence and perplexed. So that's a lot of what resistance can look like. Now, obviously, this is the extreme. You're not necessarily going to see exactly this, but a lot of, noticing that body language. Even if you're doing virtual, you'll notice people when they don't want to talk, they'll start looking away, they'll start doing something else. I've seen people play with their phones, start texting somebody, trying to wander off in their, in their head and kind of watching whatever's around. And even if, I'm like, hey, what's going on? What's happening in the room? They'll, oh, nothing, and just kind of, again, wander off, and then, backtrack and say, okay, they're not engaged. What am I doing that may be preventing that engagement? You'll get yeah buts. And then one of the more passive ways that you can see, those are all like more active ways to see resistance. But when you start getting no-shows and cancellations, now obviously life happens. So cancellations are gonna happen from time to time. But when you have, frequent no-shows, cancellations, people not calling back, that is definitely something to explore with yourself and also with your individual, but with yourself on, okay, so what happened here that may be getting in the way for engagement with this individual at this time? And it's just something to explore again. Let me see. Oh, geez. There we go. So another thing that might get in the way is secondary gains. Secondary gain is defined as an advantage that occurs secondary to the stated or real illness. Transition into a sick role may have some incidental secondary gain for patients. Types of secondary gain include using illness for personal advantage, exaggerating symptoms, consciously using symptoms for gain, and unconsciously presenting symptoms with no physiological basis. These symptoms may contribute to the social breakdown syndrome and the patient's choice to remain in the sick role. So part of the reason why I kind of wanted to talk about secondary gain is some of our individuals, they have had, use has been so significant in their life that identifying anything but where they're at and using is something that they necessarily can't think about. When you have somebody, especially when they're motivated from an external factor, when you have somebody that's coming in and they're not necessarily ready for or exploring, ready to even explore the change, identifying as somebody that talking about their social roles. They'll talk about different things that how they benefit from their use. So therefore those benefits have that secondary gain. So what do you have to lose? Some people start using early in life. So that piece of identity, that habit, that everyday lifestyle can be, it's scary to change that. It's scary to walk away from something that you know, the only thing, or something that you've done for so long. Developing coping can be delayed depending on where they started to use. So looking at the coping skills that the person has and looking at what role that use has played in their life and developing different types of coping skills with them would be beneficial. But again, it's their lead. So we're definitely kind of looking at where they're at and how to move forward with them in that way. Are there sober supports? If somebody's going to lose all of their supports, and that goes along with that team and socialization, if they're going to lose all of their friends, if they're going to lose any social type of activity, that gain, that ability to socialize, when that's lost, it becomes, that's again, another scary thing. That's something that's really hard to lose and give up. So what are they gaining from using? They're gaining friends, they're gaining opportunities to hang out with people, they're gaining opportunities to get out of a house that they might not want to be in because it might be a stressful environment. And looking, exploring that and asking, what does this mean to you? How does this help you? And exploring those types of things could be very beneficial. How much of their identity is linked with their use, I kind of spoke on. And do they have few expectations or do they fear failure? If somebody's feeling that this is the only direction that they can see their life going, if they've lost hope, then they have any vision of the future to lose, if that makes sense. Again, I wish that I could see to make sure, but I'm just, it's moving when somebody doesn't, when they feel like they're stuck, when they feel like they're in a place that might not look different, and they're feeling that they may fail if they try to move forward, and then that reinforces all of their core beliefs. Staying where they're at helps them again feel comfortable, and so that's what they get out of it. That's the gain that they get out of it. Avoiding memories, disappointments, guilt, shame. When somebody comes out of use, when they stop using, a lot of people that I talk to, almost I would dare to say almost every person I talk to, when they're no longer using, has this guilt and this shame of behaviors that were exhibited when they were using. And looking at that for them can be very scary. And so what they're gaining is a piece or a consistency or an escape from being able to not face things that may have happened to them, things that they may have done, people they may have harmed. I mean, when you're looking at the 12 steps, these are things that they address as you move around and move down in recovery. And so it's things that people will be resistant for change because it's something that's scary to see. I've had people talk about their guilt, their shame, what their use look like, the things that they've done, not wanting to face people, not wanting to talk to people, wondering why people still are by their side. And again, what they gain from not facing that is they don't have to feel because they're using, and they numb that. So moving forward in resistance, one thing to look at when we're moving forward in resistance is making sure that you're engaged. The person is engaged and you're engaged. Allowing the person to be heard, seen, feel that they're heard and seen. A lot of what I know that I had a idea that engagement looked like casual conversation, somebody just kind of to sit down and talk to, and that actually, if it's going well, that's what it looks like. But there's a purpose for that engagement. It's looking at making sure that that person has a support, has somebody to listen to them, that they're feeling supported, looking at the pros and cons of their use, and not just the pros or the cons, not having your own agenda on, okay, I'm going to show them why they shouldn't use, but looking at the pros and cons of using, pros and cons of not using, looking at what all of that looks like to them, and then exploring that and seeing where they're at. Doing a cost benefit analysis. What is the cost to you? What is the benefit? That way we can really look at where a person is, so then we can meet them where they're at. Because again, if you're not meeting people where they're at, if you come to them with your own agenda, if you're trying to do what you feel the expert would do, you're again going to create resistance. Validating. Sometimes it's the first time that somebody's been validated in their life. Their emotions are their emotions. And people come to me and we get talking and they're like, yeah, but I can't feel that way. Or my mom told me I should just suck it up. Or my husband said I should just bear with it. Or I was crying and they told me to stop. And, teens will say, I was angry, but my parents told me I wasn't. And saying, your feelings are your feelings, and actually putting a language to it and talking about the emotion and allowing them to maybe sometimes learn the words the first time for emotions that they felt for a long time, and validating what that is, exploring what these emotions are, because so many times people focus on trying to minimize the emotion because other people are telling them that they shouldn't feel that. So they must be wrong because other people are saying that. And that's not necessarily what it really looks like. Using open-ended questions. What is my favorite word to start with? Because that allows for, what does this mean to you? What do you, what are your expectations for this? It allows it to be very open. Anything that's going to produce a 2 or 3 word answer is, sometimes it's necessary because like you're doing your biopsychosocials or, your assessments, but for the most part, leaving those open-ended questions for somebody to be able to answer so you can then explore. And then as the person is answering this open-ended question, reflecting back what you've heard, because usually that will lead to more information. Reflections should, they'll always look like kind of summarizing in what you've heard from the individual, and the individual will tell you if you're right or wrong. And it also helps you realize if you guys are on the same page. If you are nowhere near, they'll say, no, that's not really what I'm feeling. And then you can get more description, more information to be able to follow along with them. So I have the last of the 3 polls that are coming up before we start talking about contingency management. So if we could put up that poll. I'm just wondering if anybody's heard of or worked with contingency management in the past or currently. Okay, so about a little over half of you aren't familiar with it. Some people have heard or read about it. Some people work at an agency that uses it, and some people work with it themselves. So contingency management is receiving tangible awards to reinforce positive behaviors. So working a job, that's very similar to, well, it is contingency management. I go to work, I put in my hours, I get paid for that. If I don't work, I don't get paid for that. Like, it's that give and take. I've worked in agencies that will provide food. If you come and you engage in this, whatever, this meeting, this type of training or whatever, that, you know, you'll have food. There's some type of benefit you get from engaging in that. So 2 examples also can be like a voucher-based reinforcement. So the example that was given on drugabuse.gov was a community-based program for opioid use and stimulants use. They used a voucher system that had monetary value to exchange for items that are received when you have a negative UDS, urine drug screen. I know that when the pregnancy center was open pre-COVID, they had, if you went to classes, you got vouchers to be able to then go to the baby store and get diapers. That again is a contingency management program where, you know, you get this education and then we will then give you something in return. So contingency, this for that. Prize incentives, giving entry to drawings for prizes worth $1 to $100 for a negative urine drug screen. An example that here at Community Mental Health, I'm not sure if we're doing it now since COVID, but before, you would get a ticket for attending groups, and then you could write your name, you could enter the ticket into a drawing, and people would win gift cards for that. So that in itself is a contingency management program, kind of helps increase incentive. So a study that I found was a study of 800 individuals from 14 US clinics with people with stimulant misuse. They were randomly separated. One was a group of twice weekly drops that had, well, one was just standard treatment where you had groups, and so that was the one. The other one had that standard treatment, and then it also had these drops that were linked with contingency management. So they were entered into a drawing for $1 to $100. The results were very interesting to me. So when the retention into the program, 49% of the people stayed in the program with contingency management versus 35% without. The mean number of weeks abstinent is 4.4 with the contingency management, 2.6 without. And the sustained stimulant abstinence was 4 times higher than without. So you were looking at 18.7% sustained abstinence in comparison to the 4.9% without. And I think that speaks volumes, because when you have something to assist somebody with their motivation, again, going back to what is their motivation for being here? What is their motivation for change? Is it family? Is it a PO? Is it a court order? So if those are the things that are motivating you, you expect a return in that, successfully completing probation, being able to re-engage with family members. With this, it's an instant return, and then it also encourages those behaviors for a period of time to then be able to help people sustain their abstinence. So I actually do have time for this video. This is to me, it's a classic. I've seen it a million times, and I'm assuming some of you have. But this talks about when you come in as an expert and you come in with this simple answer and you don't listen to the person, again, you'll catch resistance. And so this is, I guess, another example of what not to do, with a little bit of a comedic twist.
Dr. Switzer?
Yes, come in. I'm just washing my hands.
I'm Catherine Bigman. Janet Carlisle referred me.
Oh, yes. Fear of being buried alive in a box.
Yes, that's me. Should I lay down?
Oh, no, we don't do that anymore. Just have a seat. And let me tell you a bit about our billing. I charge $5 for the first 5 minutes. And then absolutely nothing after that. How does that sound?
That sounds great. Too good to be true, as a matter of fact.
Well, I can almost guarantee you that our session won't last the full 5 minutes. Now, we don't do any insurance billing, so you would either have to pay in cash or by check.
Wow. Okay.
And I don't make change.
All right.
And go.
Go.
Well, tell
What?
me about the problem that you wish to address.
Oh, okay. Well, I have this fear of being buried alive in a box. I start thinking about being buried alive and I begin to panic.
Has anyone ever tried to bury you alive in a box?
No, but truly thinking about it does make my life horrible. I mean, I can't go through tunnels or be in an elevator or in a house, anything boxy.
So what you're saying is you're claustrophobic.
Yes, that's it.
All right, well, let's go, Catherine. I'm going to say 2 words to you right now. I want you to listen to them very, very carefully. Then I want you to take them out of the office with you and incorporate them into your life.
Well, shall I write them down?
Well, if it makes you comfortable, it's just 2 words. We find most people can remember them.
Okay.
You ready?
Yes.
Okay, here they are. Stop it!
I'm sorry?
Stop it!
Stop it?
Yes, S-T-O-P, new word, I-T.
So, what are you saying?
You know, it's funny. I say 2 simple words, and I cannot tell you the amount of people who say exactly the same thing you're saying. I mean, this is not Yiddish, Catherine. This is English. Stop it.
So, I should just stop it.
There you go. I mean, you don't want to go through life being scared of being buried alive in a box, do you? I mean, that sounds frightening.
It is.
Then stop it.
I can't. I mean, it's been with me since childhood.
No, we don't go there. Just stop it.
So I should just stop being afraid of being buried alive in a box.
You got it. Good girl. Well, it's only been 3 minutes, so that will be $3.
Actually, I only have a 5, so
Well, I don't make change.
then I guess I'll take the full 5 minutes.
Fine. All right. Well, what other problems would you like to address?
I'm bulimic. I stick my fingers down my throat.
Stop it! What are you, nut of some kind? Don't do that.
But I'm compelled to. My mom used to call me fatty.
No, we don't go there.
But I've been having this dream.
No, we don't go there either.
But my horoscope did say...
We definitely don't go there. Just stop it. What else?
Well, I have self-destructive relationships with men.
Stop it! You want to be with a man, don't you?
Yes.
Well, then stop it. Don't be such a big baby.
I wash my hands a lot.
That's all right.
It is?
I wash my hands all the time. And there's a lot of germs out there. Yeah, don't worry about that one.
I'm afraid to drive.
Well, stop it! How are you going to get around? Get in the car and drive, you kook. Stop it!
You stop it! You stop it!
What's the problem, Kathy?
I don't like this. I don't like this therapy at all. You're just telling me to stop it.
And you don't like that?
No, I don't.
So you think we're moving too fast? Is that it?
Yes. Yes, I do.
All right, then let me give you 10 words that I think will clear everything up for you. You want to get a pad and a pencil for this one?
Right.
Are you ready? All right, here are the 10 words. Stop it or I'll bury you alive in a box!
Anyways, that's just a little fun thing of what not to do. But kind of in conclusion, looking at resistance is created by somebody who is not engaged, who is that has something to gain to continue doing what they were doing before they came to see you. Somebody that that hasn't necessarily had positive experiences with professionals and is guarded because you represent something to them that that has not necessarily always been positive. So when working with people, meeting them where they're at, listening to them, reflecting back to them, taking the time to listen to hear, not listen to respond, being a support to them, letting them know that they're safe, that the information isn't going to be spread around, isn't going to be given to anybody else, especially with your teens. I can't tell you how many teens have told me about counselors that have talked to their parents and then they get home and they get grounded for what they said to their counselor or their therapist or clinician, whatever you want to call it. And then of course they don't want to talk about it because it's, you know, it's what they own, because that's their truth, that adults can't be trusted. People, you know, people who haven't explored feelings, who the feelings are painful or scary, and they've been using to be able to numb those feelings or avoid those feelings. And when you're asking them to take their one coping mechanism and telling them to stop it, for lack of better terms, to look at change, to be able to move toward recovery, and telling them that recovery is possible and there's hope and there's a future, and the future can look however they want it to look. It's something that they may never have heard or not believed before. So I guess in conclusion, working with people with resistance is about just listening. I mean, if it can be that simple, and allowing them to take the lead and be heard and be an expert in themselves instead of telling them what should or shouldn't happen. So I know that we've only got a couple of minutes, and I don't know if we could take a couple questions.
Shannon, we do have a couple of questions, so I'll read those off. Someone asked, there may be a lot of barriers that we could foresee engaging with clients who are resistant when it comes to telehealth services, because a lot of people, that's really the only option at this time. Any suggestion on ways to improve engagement through telehealth services?
I get kicked off for a second and I just got back.
Can you hear? Okay. Did you want me to reread the question for you, Shannon?
If you could, please.
Sure. Okay. With a lot of folks using telehealth services right now, there might be some difficulty in engaging clients